Good day, everyone. I hope everyone is well. My name is Dan Serrano. I'm a principal and senior vice president with Cope Health Solutions. I want to thank everybody for taking the time to join us for our conversation today regarding the importance of data exchange and advancing equity and healthcare transformation, right? In the redefinition of whole person care and some of the recent advances in the state of California and across the country, and the importance overall of really putting data in the hands of clinicians at the right time in the right place. I have three fantastic panelists that I'm lucky enough to have join me today with tremendous depth of expertise, knowledge, and just overall subject matter expertise, both in healthcare and in these particular topics. I'd like to just do a quick introduction of folks. Lisa Chan Swan is the CEO and founder of Transform Health, a national woman and minority-owned consulting firm. Having studied the Medicaid reform system for over the last 20 years, she's collaborated extensively with government agencies, healthcare providers, foundations, and health plans to develop and implement health system transformation projects. Lisa has led numerous teams in the design of system change initiatives, and she continues to advise and support state and local governments across the country as they enact broad multi-sector engagement strategies. Her previous work includes providing strategic guidance and subject matter expertise in several states, including the development of the Medicaid 1115 waivers in California and New York. Under her leadership, Transform Health currently runs stakeholder collaboratives in LA, Sacramento, Fresno, Madera, and Kings County in California. Just a tremendous depth of experience. We're so thankful to have you join us today. Additionally, Adamika Arthur, a visionary and accomplished healthcare executive with over 2 decades of experience, particularly in the realms of health equity, investments, and disruptive technologies. Her insights have proven time and time again invaluable to companies navigating the ever-evolving healthcare landscape. Adamika is known as one of her monikers is Madam Medicaid for her tenacious involvement in the 2005 California 1115 waiver to expand Medicaid. Adamika's career is extremely successful and depth of accomplishments has been marked by her remarkable ability to transform business use cases and forge strategic partnerships in complex regulatory environments, both domestically and globally. She is a cross-disciplinary collaborator known for her knack in crafting innovative, customer-centric solutions that yield tangible results. Adamika, thank you for being here. Additionally, Ravi Mariwala, thank you for being here. Ravi is a principal director in the healthcare business unit at LTI Mindtree, a global IT services organization. Ravi began his career in cardiac OR, where he worked as a clinical perfusionist before taking up P&L responsibility at a 100-bed medical center. Ravi worked with large IT services organizations like Cognizant and BBC Analytics Unicorn Innovator prior to joining Optum Advisory Services, where he led the provider digital strategy workstream. He's led engagements in advisory businesses and technology consulting, EMR modernization, virtual care platform readiness, automated care management, platform development, advanced analytics, interoperability, and population health management. Thank you all again for joining me today. Greatly appreciate it. Just a couple of quick items on housekeeping. Please enter any questions through the Q&A feature on Teams, as you can see in the screenshot. If you have questions, you may also email them directly to info@copehealthsolutions.com. Attendees will receive a PDF copy of the presentation and a link to the recording and written Q&A. After the presentation, we will likely send out a brief survey, and we greatly appreciate any of your feedback and comments. So I think, jumping in, I'd really, Lisa, if I could pose a question to you, can you help folks understand what is DxF, and why should organizations care about it, and what are the goals to it?
So if Alice, if you don't mind putting the slides on, we have a few slides that we'll send them out to everyone, but it'll give a good grounding about what is California's vision for data exchange and what the data exchange framework is. So I'll go ahead and start while we're advancing the slides. So, California has been going through a journey evolving its healthcare delivery systems. We started in the prior waiver with 1115 waivers, and it has continued with the current CalAIM waiver. If we could go back one slide. Oop. Perfect. Thank you, Alice. So I want to just start here. This is California's vision for data exchange, and it really became apparent and obvious after our whole person care pilots, health homes, everything that came out of the last waiver. We as a state in California realized that every Californian should have access, and their health and social service providers that care for them should have timely and secure access to usable electronic information, really at the point of care, to support patients address their health and social needs, recognizing that we need to see the whole person, that a lot of care can be disrupted if there are social determinants, challenges in individuals' life, whether they're food insecure, housing insecure, they may have mental health or substance use disorder needs, and those issues could get in the way of supporting their ability to address their healthcare needs. So we wanted to start here because California's vision is that we bring everyone together to wrap around the patient, wrap around the providers, and have this data at the provider's fingertips to best support patients, recognizing that there can be many, many providers that are serving the same patient. Next slide, please. So as we think about the data sharing agreement, California passed AB 133. It's a new law that went into effect this past January 1st, 2023. This law established California's data exchange framework and the state's standardized data sharing agreement. The law requires all entities in healthcare, and this includes hospitals, doctors, IPAs, nursing homes, clinical labs, you name it, to sign one statewide data sharing agreement. It's called the DSA, and begin sharing data by January 1st, 2024, following a common set of policies and procedures. It is broad-based. It is intended to include everyone operating in the healthcare sector, regardless if you are operating and providing services through Medi-Cal, Medicare, or commercial health insurance. And on top of that, it also encourages optional signatories to do the same. These optional signatories include counties, CBOs, folks on the social service side, housing agencies, for example, food pantries and like, to also sign. They're not required, but if they do sign, they would be expected to exchange data by 2026. And many people ask, well, geez, I have a lot of existing data sharing agreements. What exactly is this DxF? And what does signing the DSA mean? Well, essentially what you are agreeing to is to operate following a common set of rules of the road. It does not supersede your existing data sharing agreements. Your BAAs will still stand. However, it's important to realize that what the state is doing is we are setting a floor and expectations for how we are moving forward and sharing data as we evolve healthcare delivery systems as we look towards the future. Next slide, please. So this slide shows who has to have signed by this past January. Now, the good news is there's no penalties if you haven't executed the agreement yet. You'll see here it is fairly broad-based. Currently, there are no penalties. However, this is an evolving landscape. The state really wants to know who is going to be ready to begin exchanging data next January. They just this past week certified a number of health information exchange organizations. We're calling them QHIOs, or Qualified Health Information Organizations. And essentially what we're doing is we're setting this floor. We're telling providers, plans, organizations operating within the healthcare space to exchange data in a very specific way, leveraging these QHIOs, these health information exchange entities, to support those efforts. Many of you are probably wondering, well, how does this even fit with the national landscape? So if we could go to the next slide, what California is doing actually does fit in to the broader national landscape. There is a federal law called TEFCA, the Trusted Exchange Framework and Common Agreement, that also does something similar. It outlines a common set of principles and terms. And what the federal government is expecting is that across the nation, there will be these qualified health information networks. So networks of HIEs that come together and become networks of networks. And so this is the path forward for national interoperability. So California is a bit ahead of the curve. We are putting out significant resources to really establish those rules of the road. There is a new state agency, the California Center for Data Insights and Innovation, that is establishing these common policies and procedures. And when you sign the state's data sharing agreement, you're essentially agreeing to abide by those policies and procedures. And because they will be cross-cutting across entities, they create these common rules across the industry so that we can have that broader base interoperability and data sharing. And of course, this takes resources, right? Signing the data sharing agreement does not mean we're going to be interoperable. Thank you. So this is the national landscape, and you'll see here California's QHIOs will probably band together to become a QHIN, and the feds are expecting all the QHINs to be connected across the nation. But getting to my point about the point that I wanted to make next is these types of changes requires funding. And so if we can go to the next slide just to do some level setting, California has also recognized that this is costly and that there are some providers who did not get meaningful use dollars, may not have qualified for CalHOP dollars, but really do need some supports to be able to become interoperable, to be able to evolve their policies and procedures. Maybe you need to evolve and make some changes to your EHRs. Well, the good news is the state has set aside dollars. There's $47 million in grant funding, and there are two types of grants. You can go through the QHIOs, where it's an assisted pathway. There is significant support, and we highly encourage particularly smaller organizations to look at the QHIO onboarding grants, because those grants will partner you with QHIO, and folks, I'll pop my email in the chat. We're happy to share who the QHIOs are now that they have been announced. They're folks like Manifest Medics, Lanes in Los Angeles, but the state is willing to provide dollars to support providers, plans, stakeholders to be able to meet these interoperability goals. And the dollars are available this year. It is unclear if they're going to be available next year. So there's currently a round open now. It opened October 16th. You will be able to apply. However, we also know that there are some folks who are more sophisticated, or maybe they need investments in technology. So the state has allowed providers to and stakeholders to apply for either the QHIO grants or the technical assistance grants. Those TA grants are more build your own solutions. You can use those dollars to pay for platform changes, technology changes. You can hire a consultant with those dollars. There's more flexibility. However, you will not get the hand-holding from a QHIO through a TA grant unless you make arrangements to pay them separately. Under the QHIO onboarding grants, the state gives the money to the QHIOs, pairs you up together, and the QHIOs are supposed to walk the journey with you. Next slide. Of course, everybody wants to know, well, how much money really is available to me? And these dollars are for each unique instance of an organization. So if you're a hospital, skilled nursing facility, you get $50,000. And if you are serving underserved communities, if you didn't receive past high-tech funding, that amount doubles. And so you can see it goes up to $100,000 per instance per organization. Physician groups starts at 35,000, goes up to 50, and you'll see here plans, clinical laboratories, and other DSA signatories can definitely apply. And the other DSA signatories also include the optional signatories. So counties, community-based organizations, social service agencies would be eligible. Of the $47 million that the state set aside, there's still $30 million left, $30+ million. So the time is now. And if you secure these grants, you can use them for 2 years. So you hold the dollars, you secure the grants, and you will have time to expend those dollars. Next slide, please. And on top of that, the state is also allowing groups of organizations to come together to apply under umbrella applications. And this is really great because sometimes, like, for example, maybe an MSO or an IPA who's working with a lot of individual unique organizations can apply on behalf of the entire group, and each organization with their own instance underneath the group would have their own dedicated source of dollars. So this streamlines the application process. There's a lot of technical supports available. And so we want to tell organizations, talk to your trading partners. Who do you want to exchange data with? Who do you need to come into the fold as you think about where you need to go in the future? And so we are happy to share more information about umbrella applications. We're happy to plug you into the technical assistance support. And if I'll end, next slide, with help and where to get it. I mentioned there's a lot of funding sources available for supporting provider organizations. We talked about these QHIO technical assistance grants. If you are in Medi-Cal and working on CalAIM, you would also be eligible for path-cited funding. There's also an incentive payment program that has the flexibility. Those are run through the Medi-Cal managed care plans. And so there are multiple sources of funds that you might be able to apply through to help provide some financial assistance. And there's a lot of technical assistance available. There's the PATH Technical Assistance Marketplace. There are educational grants, and folks like our organization is trying to help folks like you plug into the right resources. We've partnered with Connecting for Better Health, which is a nonprofit organization, and it's a statewide data collaborative. And we highly encourage folks to join that because this is an evolving conversation. There are a number of policies and procedures that have been developed, but a few more that the state's still taking public comments on. So you'll want to track what's going on, and that is a great resource to have. We have a lawyer that joins every month, so you can come to that meeting and ask your questions. We provide updates on where any policy changes might be happening. So we highly encourage folks to stay plugged in. But I will end there because I know we've got a lot of other things to talk about.
Lisa, thank you so much. What a tremendous overview. Really, great detail. I think sparks tons of follow-on questions. So in that spirit, Ravi, if I could ask you, I'm listening to Lisa explain how all the QHIOs are supposed to be set up, and the thought about moving these rules around data collaboration, not just statewide but more nationally. Can I ask you, what comes to mind when you think of potential technology impacts from this new data exchange program, and what kind of, if any, challenges do you foresee with this type of plan and this type of implementation, not only in California, but as it moves more nationally?
Yeah. And thanks for the question. I think, it's a tough act to follow what Lisa did. She really gave us a deep dive into this complex, legislation. And I've been fortunate to have worked on the ground in a clinical setting, right, and then moved into technology services. And I can clearly see 2 or 3 things happening over here. California, of course, has taken the lead, and sometimes I think, why am I based out of North Carolina? I should be saying North California, right? But California seems to be the happening place. And, I got lucky. I was part and parcel of work that happened in New York when they launched DxF, which is a similar program, but I think California is far ahead in terms of leading the nation towards interoperability. So, at the cost of sounding sort of using a cliche, I want to restate that statement, which says that data and information is the oil of the 21st century, and analytics is the combustion engine. So I know we are referring to the industrial revolution, and today there is only talk of Gen AI. But I think this program, what it brings to mind is the fact that it is a very ambitious program, right? There is a lot to be done here. Basically, all data sharing and receiving entities have to look very closely at how they can put technology to work, right? We are paying a lot for technology investments. We have to get them to work, because what is the point of all the data capture that we do if we are not able to share it? And on sharing the data, if we are not able to make sense of it, right? So I think it is an ambitious program. It is timely. It is very relevant in today's context, where health equity has taken an important place in being one of the key business objectives that we want to drive towards. So I think all of that is good. The third thing that comes to mind is the fact that the state has on purpose left it technology agnostic. I think that is a very big step in the right direction. If those who are familiar with work that happened with meaningful use and the High Tech Act, and subsequently, how that morphed into what is called promoting interoperability, right? All of those pieces of legislation were very prescriptive. And some providers say in jest that it broke our backs, right? So they were tough, they had to spend a lot of money, there was limited incentive provided by grants and funding. But I think uh, keeping it technology agnostic with some guidelines, as they've done, right? They've called out fire standards, they've called out the US core data interoperability standards. They've named the 3 or 4 data formats such as the CDA, etc., to be used. So I think the state has provided enough guidance, policy and procedure. They've also provided a set of guiding principles, right? And then they've left the rest to the QHIOs and other entities who are going to take technology and put it to work effectively, right? So I think these 3 things stand out in my mind. Of course, recognizing that it's an ambitious program, to thinking about how data reciprocity needs to be handled, right? Because no point just capturing the data, reciprocating with the data, sharing it, and driving it in the direction of health equity. That's the second thing. The third thing is, like I said, keeping it slightly open in terms of the how, right? The what has been defined. Now it's for the technology vendors, the health systems, the health plans, the labs, and others to determine what exactly they want to invest in and how they want to drive towards that goal of interoperability. Now, coming to your point, Dan, about the challenges, and I'll take another just take another minute. I do want to hear Adamika. I heard her at HLTH in a couple of sessions, and I know she'll have some awesome thoughts to share as well. So talking about the challenges very quickly, I think the way I've learned to look at technology investments is always in terms of the digital maturity, right? And I think, Lisa, you alluded a little bit to that. We still have in the country, and definitely within California, some of the entities who have remained paper based, right? And I hate to use the word one end of the spectrum, but they will have a longer journey. They'll have a bigger investment cycle. They'll have more catching up to do. And I'm sure the government and the funding programs Lisa alluded to are meant to support them. But clearly looking at the continuum of where a care delivery organization sits today with respect to its digital maturity is going to matter a lot in how they approach and attain the goals of data sharing. The second challenge that I see coming up, which I think people are not adequately prepared for. Yes, we do want all the information about every patient we are seeing, but we haven't truly understood what making that information available is going to do to the providers, right? Providers who would engage with patients and look at a short list of their medical records are now going to have to face a different challenge, right? So there's always a good side of what we are doing, and there are some potential challenges that come up because now they'll have a lot of data to grapple with, right? They'll have to look through a lot of more records, because if they don't, there'll be a shortfall, and they'll be liable for not having delivered the best care, right? So there is that element of putting a lot of additional workload on these providers. And I don't really see that as a problem, because I think in these days of technology, I'm sure technology vendors like ourselves and all of you will work to find a way not to throw and dump more raw data at these providers, but figure out a way to, again, put technology to work to bubble up key pieces of information, use AI to find what is it that matters to this provider who's looking at this patient in this part of his journey or her journey, right? So there's a different approach to looking at information when you're discharging a patient versus when you're admitting a patient, right? So putting data in the right context and bubbling it up in the form of insights, I think there's a big opportunity that is going to arise, though we are not talking about it today as part of the DxF, the data exchange framework itself. I think it's going to be a challenge, which when providers start facing it, they're going to look for AI to help solve that challenge. The last thing I'll say and then keep quiet is that, we are probably underestimating what's going to happen in terms of the security challenges that will arise when there is a heightened level of data sharing between entities, many of whom continue to have legacy systems, right? So when we use the word legacy system, it's not meant to slight the organization, but it's a fact. It's what they need today and what they've survived with. It delivers for them. Now all of a sudden, when they have to take that leap into being able to share and receive data, I think those legacy systems need to be looked at very hard to figure out if there are vulnerabilities from a security standpoint. So I'll stop with these three challenges. I'm sure there are more, but I think these are the primary challenges that come to mind. The first being the fact that one has to start by looking at the organization's digital maturity and planning for the journey. The second being we just don't want to increase the workload of the providers. We want to make it a cognitively enabled, engagement that they continue to have with their patients. And lastly, pay a lot of attention to the likely vulnerabilities this creates from a security standpoint.
Ravi, thanks so much. Such great points. Completely agree with both the opportunities and challenges that you've pointed out. So I think Lisa has given us a tremendous kind of overview of the exchange framework. You've really helped us understand some of the opportunities and challenges. And so I think you were reading my mind a little bit as well as I think about, from a financial perspective and from a return on investment, right? We have to use this data to actually make a difference in patients' lives. And so, Adamika, I turn to you to ask you, what does this really mean when it comes down to brass tacks? Like, how can this be leveraged? How can this information be leveraged to address actual healthcare disparities? How do we really take this information and help people with these social determinants? Drive better care, make it more holistic. Really, even if it's means something out of the traditional purview of what we call medicine. How do we any examples of how you think we could take this and really drive better care?
Sure. So first, good morning, and I really appreciate the opportunity to chat with everyone today. What I will say is I'm an epidemiologist by training, so I will just put my occupational hazard out there that data is a love language for me, and I say that in prefacing this because people like me, there's never enough data, but the reality is. When you're thinking about redefining whole person care, what does that really even mean? None of us have whole person care today, right? And so when I think about whole person care, I think a little bit about some of the fundamental tenets around how advancing equity can actually help your quality and duration of life, and not just for you, but for your family members, for the people you caregive for, whether it be your children or your parents or spouse, but also ultimately your community. And I think that when we talk about this, I just want to kind of break it down in a few ways. Ultimately, what we're trying to talk about is really the common theme around how do we have, quote, value-based care, right? How are we improving quality, making things better, and understanding for financial performance, right? Through the lens of value-based care. And I think that we have to think about the context of healthcare transformation and specifically equity within those. And I do index that because I think there is a big difference between populations, and we're just now thinking about that. And in order to have whole person care, we've got to really think about the intersections, right? So the concept of whole person care is really emphasizing a holistic approach to healthcare, right? And so that's one thing, right? The other thing is like how data exchange is a fundamental enabler of whole person care. How can we use data to actually have this more holistic approach to healthcare? And how do we look at it from all stakeholders' perspectives? I think oftentimes we index solely on healthcare providers' perspectives. But how can we flip that and really start to think comprehensively around a person or a patient experience, or a caregiver experience, or other systems that we've not traditionally had as a part of our conversation as we talk about whole person care? And I think, while I think plenty of great things are going on in North Carolina, Robbie, because I am super excited that the 40th state to expand Medicaid, for somebody who's been working on this as long as I have, in North Carolina. And models around the country. And I know California is seen as a leader, but I don't want anyone to be discouraged, because there are incredible models out there that we're seeing in states like Oregon and Ohio and even Oklahoma, right? I'm just sticking with the O's right now. But I think it's important for folks to not think that that there's a lost leader in this. We're all trying to make care better. And so if we index on, and that's the one interesting and wonderful unique thing about demographics. But I think that in order to do whole person care well and to think about data exchange in a good way, you really have to think about how do we address health disparities as a part of that conversation? How do we highlight the disparities in healthcare outcomes? How do we deal with access related issues that impact specific populations more, whether that be dual eligibles or young children? And how do we emphasize how data exchange can help identify and address these disparities through kind of data-driven interventions? Another area, and I know Robbie spent a lot of time talking about interoperability and some of the opportunities and the challenges. One of the things I want to make sure people think about, not just the things around data security and privacy, but really around the person-centered approach to data sharing, meaning moving and shifting towards people being empowered to manage their own healthcare, and looking at different sorts of patient portals and data sharing initiatives that we're seeing. And a couple other areas that I think are really exciting. I know Lisa touched briefly on the policy and regulatory considerations around data exchange. I look at them specifically in Medicaid, which has a lot around healthcare transformation and equity right now, and population health management. But I also think we should think about some other areas. One around telehealth integration, how the integration with telehealth with data exchange and its role in expanding access for folks. And also another is the incredible collaboration we're seeing today in states and federally, but really stressing that importance of collaboration and standardization amongst agencies to ensure effective data exchange and interagency collaborations, which it's very exciting to see. But I think you talked a bit about like what are some real world examples, how do we see this working well? I think the biggest thing is to not lose sight of the people in which we're building this for, right? And I see Robbie put in a note here around the collaboration right between COPE and LTI Mindtree, and maybe it's worth hearing some of the solution accelerators that you guys are utilizing, if we can do that. Dan, I don't want to take over your moderating ability, but I do think that we've talked a bit about the landscape and the frame and the background. We've talked a little bit about some of the challenges. I hopefully have sparked a little bit of the opportunities. But it'd be great to know some of the examples. And if there's folks in the audience who, most people who know me know I love an interactive situation, also have some great ideas, it would be really good to hear about some real life opportunities. Did I answer your question well, Dan?
Yeah, I appreciate that. Thank you so much. And to your point, at Cope, our ARC platform, or the suite of products we have, is just a tremendous asset for providers and payers alike, focused on data interoperability, bringing together all these disparate data sources, whether it be claims and eligibility, EMR data, SDOH data, lab data. We're trying to paint the picture as completely as humanly possible for, not only providers on the ground, but management teams, payers, providers alike. We want to look at all the things that are, key to being able to manage these disparate populations, be able to highlight what's important, what actually drives, differences in both cost and quality, the ability to dive, not only see at a high level over time how you're doing, but really be able to drive deeply into the details so that you know what's actionable, and really reducing the data overload, or the burden on folks who need to use this data to actually go out and make a difference. So we have really robust not only ingestion engine, but also tremendous reporting that we can enable folks with to see their populations from a number of different perspectives, and really appreciate the interaction and interplay between all these different variables, so that it gives a real, both longitudinal and then just a holistic view of what it takes to take care of patients, and what makes a difference in the execution of some of these clinical initiatives. I'll stop there myself. I know we're at about quarter to the hour, and I want to leave some time for questions and answers. So I'd ask that for any of the participants, as we mentioned earlier, either questions in the chat, or send your questions to info@Cope Health Solutions, and we'd be happy to respond to that.
Adamika, I love, as folks are popping in their questions in the chat, I just want to say I love you bringing this back to the patient, back to the why. And what really comes to mind, I really love that you went real world example. One real world example that I'm happy to share, came from our Sacramento Whole Person Care pilot 7-8 years back. We didn't have the same abilities, the desires. We didn't have this law, and the platforms didn't have the level of sophistication. So we had the fun job of trying to connect housing providers, clinics, CHWs, serving the same patients, when we ran a pilot focusing on chronically ill homeless, the sickest amongst the sick, who are cycling in and out of EDs. And we built a common care management platform where each provider entity serving the same patient could see a common record, share information about information pertaining to that individual, and do community level huddles around how to coordinate care and services. And I can share with you, it was incredible for those providers to have that information at their fingertips. In these huddles, they would communicate, like they would talk about things like, oh, this individual has a housing appointment coming up. We've been working on their housing, and we're planning on doing it on this date. And the clinical care coordinator would be like, oh no, that's the date that they're getting a critical specialty care appointment that we've been waiting 6 months for. And so just even that sheer ability to do that level of coordination was incredible. And the Sacramento Bee wrote about this one case that really stuck out in my mind. It was a woman who had been chronically homeless for over 30 years. She had left Washington State because of a felony. And so when she entered our program, she had a host of health issues. She'd been homeless. And so we had to help her in a lot of different ways. But as we had to help address the housing so that she could have the opportunities to stabilize. But what was even more powerful, it was powerful, and data was such a key piece of that, because their providers within a year were able to find her housing, started addressing her diabetes, her COPD. And what was really blew my mind, she was an incredible case for us. And when we were able to share her story more broadly, the SACB picked it up, AP picked it up. And when she had left Oregon over 30 years ago, she had left behind a baby girl, and her daughter had not known her mother her entire life. And after she saw the article and contacted our program, and we were able to connect her and her mother. And that really is the power, right? Like, not only were we able to address her the social needs that she had, her housing needs, as well as her healthcare needs, but at the end of the day, it's about people and it's about connection. And so to be able to do that, we should be able to do that for everyone, and to really see them holistically.
Yeah, I think that's really wonderful, Lisa. I just wanted to touch on, Heather wrote, is there a way to look at office hours or other ways that we can get like more personalized or specific information? I encourage you to reach out, and I'm certain that the COPE team will reach out potentially after this and try to see how they can answer questions. I also just want to say there's an opportunity right now in the midst of Medicaid redetermination across the country. We just the most recent data that came out earlier this week looks at over 9.5 million people who have now gotten procedurally kicked off of Medicaid. So we have a real opportunity now to start to figure out what information do we need, how do we capture that information, how do we do this in a way in which we knit together the fabric of each of the communities in which we, eat, pray, live, work, etc. And I think, Heather, that approach to really having some support, whether it be consultant support, someone to come in and do a readiness assessment, someone to help you figure out how your strategic partnerships can line up, is a great way. And data is a great galvanizing tool. I think somebody mentioned earlier, this in some ways feels a little bit of like when we had carrots that were out there that were helping us with getting to EHRs. Let's use this opportunity and this time as a carrot and leverage the resources that are available. Have consultants or others help you figure out how do you maximize the dollars that are literally out there for you. And so, it doesn't have to be a budgetary hit, but it really can impact, especially in this critical time in the next likely about 6 to 9 months during Medicaid redetermination, where it's going to be really critical that our communities have access to delivery system care.
And for folks in California who are actively trying to do this, yes, there are absolutely office hours. We're happy to plug you into those office hours. We actually, in partnership with Connecting for Better Health, run a monthly office hour set where we partner with a healthcare lawyer to answer some of those gnarly privacy security concerns that we know everybody has when we think about how to safely and securely do all of this work. So feel free to reach out to me. Happy to plug folks into those efforts and other efforts underway. And just to bring this nationally, there's a lot of conversations, and many states are looking at 1115 waivers to drive innovation, and to also address social determinants of health. CMS last December issued a health equity framework of which states can pursue funding for housing, for food insecurity. Those dollars can also fund some of the infrastructure capacity building. And it's really important to recognize if we're really going to see the whole person, we really need to understand not only what's happening in their lives with health, but also their social needs. And I'm really excited about where we're at right now. It does feel like we're at the tip of the iceberg in terms of really thinking about how to incorporate social determinants. And it'll be really exciting to see what the next 5 years looks like as we go through this journey.
Because I think, in thinking about this and just, you hear the words data exchange framework and you realize that it is a technologically heavy endeavor. Robbie, I wonder, how do you think about perhaps individuals like immediate kind of visceral reaction to, I've already spent so much money and so much time, setting up data definitions and standards, and how do you get people past the hurdle of, I've done this already? Is there a burden? Are we defining a widget as a widget, universally going forward? I mean, that in my mind it would be ideal, right? So we all know we're talking about the same thing, but there is that element of, sunk cost and time. And so I'm just curious how you think about that.
Yeah, I think that's a great question, very relevant at this point of time, especially, Dan. We all know that providers especially are reeling under the burden of low margins, right? There's inflation on the one hand, the pandemic hit their volumes, and they are you can see that a lot of consolidation even is beginning to show up and start to happen. So I think the approach we've taken as a company, right, is to be very cognizant of people's current investments, and right, we don't ever think go approach. IT assets are hard to build. They take away money from your core patient-centered activities. So I think we really like to have that advisory thinking as an overlay before we embark on technology investments, right? Only so that we are very closely aligned with the use cases to be served. We want to anticipate what's coming in the future, so that we don't need to rip and replace for that reason, right? And I think when we do that, we integrate once with 5 systems rather than integrate 5 times, when you're not deliberate about it. So that's one thing that we've learned over time, to take an enterprise architecture driven approach, be future ready, invest in technologies that are, going to last, and technologies change every so often. Got to be very careful about the technology you're investing in. And then lastly, right, I think technology is never the only answer, right? I think I heard that both from Lisa and Adamika, and that's a great point, right? Our objectives are from the business side. Our technology needs to also make sure that there is adequate room for people to upskill and to adopt the technology, right? Technology adoption is a big part of the success that you can ensure when you make those investments. So I think, when I look at the principles that the DxF has called out, I think they've been very mindful of that, right? Like I said in the beginning, they've advocated a technology agnostic approach to start with. They've laid out some guidelines, but there's a lot of emphasis not only on organizational aspects of access to data, but even individual access to data, right? So I think we are well covered here with the support that very mindful planning can bring to this whole effort. and then like I wrote in the chat, we definitely need to look at accelerators, right? How can we accelerate our technology journey so that we see early ROI, right? So that may sometimes mean, not having a very sort of magnificent vision of the future, but, investing as much as is necessary and then going and building from there. I think that is a great approach with large technology investments that will help us. But thank you for asking that question. That's very relevant, and it was top of mind for me also.
I just want to take this last minute or so to thank you all so much for such thoughtful, thorough, interactive discussion. This is clearly a topic that is going to grow, evolve, become more important, more relevant, hopefully spur significant innovation in a lot of these areas like that we know will make a difference in people's lives and their ability to get better care, especially when we talk about things like caregiver interaction and other things that help people really who are, in communities that have needs be better taken care of. So thank you so much for your participation today. Again, if anyone has questions, you please reach out to us, info@Cope Health Solutions, or the number on the screen. Again, we will distribute both the recording and the slides from today's webinar. We want to thank you all for joining. For me at Cope Health Solutions and the rest of our panelists, thank you, and I hope you have a terrific rest of the day.